Navigating religious identity in professional psychology requires operating under two contradictory sets of rules simultaneously. What works in one environment can actively penalize you. These conflicting rulebooks govern the two primary domains of the profession: clinical practice, where the focus is the patient, and academic research, where the focus is the system. The clinical environment operates on a hyper-localized scale. Here, success is measured by managing the immediate, individual boundaries of the person sitting across from you. Conversely, academic researchers must satisfy massive institutional frameworks and committee standards to validate their observations. Professional survival in modern psychology requires mastering both the strict clinical boundary and the academic intersectional mandate. We can trace this tension through primary peer-to-peer discourse between graduate psychology students. Their interactions reveal how upcoming professionals negotiate these two environments. Navigating this divide is a requirement for professional efficacy and institutional survival. There is a common assumption among culturally competent practitioners that deeply religious clients naturally want their faith integrated into their clinical treatment. The qualitative evidence from student discourse suggests the opposite. Many clients actively resist this integration, with one student noting they prefer their therapist to stay out of their spiritual life entirely. Looking at this flow, religious patients often seek therapists for a specific, scientifically grounded purpose: psychological health. For spiritual concerns, they turn to a dedicated spiritual advisor. The patient relies on an explicit barrier between these two professionals, refusing to mix roles. When a therapist attempts to act as a spiritual guide, the patient may view the overlap as a liability. This blurring of expertise risks a boundary violation that can undermine the therapeutic alliance. To maintain this alliance, practitioners must establish professional boundaries that respect the separation, validating the patient's choice to seek spiritual support elsewhere. This allows a clinician to collaborate with or defer to a spiritual advisor without crossing domain lines or diluting the clinical focus. In the clinic, respect for a patient's faith is demonstrated through the management of these boundaries, rather than through integration. While the clinic is defined by micro-level boundaries, the academic domain is defined by the macro-level friction of institutional publishing and peer review. Doctoral candidates face high hurdles when studying religious bias, as institutions require specific methodological frameworks to validate the research. One doctoral dissertation highlighted in the discourse proposed to focus exclusively on discrimination against Christians within the psychological profession. This isolated proposal met with immediate institutional rejection. This outcome is driven by a specific pedagogical rationale within university committees regarding how bias is proven: analytical. The modern psychological academy views single-faith paradigms as statistically isolated. When a variable is studied in a vacuum, committees often find the research lacks the breadth necessary to prove systemic behavior. The institution demands broad, comparative context. To prove bias exists systemically, a researcher must demonstrate how it operates across a spectrum of identities. Academic survival requires an expanded, multivariable scope to mathematically validate research into bias. To salvage the rejected dissertation, the candidate expanded the scope to include multiple world religions. Christianity was repositioned from an isolated subject to a comparative baseline within a much wider dataset. This shift satisfies a core requirement of modern institutional psychology: intersectionality. For academic committees, analyzing religious bias is considered empirically incomplete unless it is cross-referenced with racial demographics. This requires a matrix where religion on the x-axis and race on the y-axis are mapped together. This allows researchers to see where bias is altered by the cross-contamination of these two identities. The resulting data shows that bias cannot be accurately mapped using religion alone. By adopting this multivariable matrix, the candidate moved the dissertation from rejected to institutionally accepted. Intersectionality provides the mandatory operational framework for proving systemic discrimination in the psychological academy. We can now bring both sets of contradictory rules into a unified view. The clinical mandate prioritizes patient outcomes by maintaining clean boundaries between psychological treatment and spiritual advisement. The academic mandate anticipates institutional friction by forcing race and comparative religion to interact in the data. Professional efficacy is achieved through this flexibility. One must adopt a restrictive boundary for the individual patient, but an expansive intersectional scope for the institution. Failing to clearly distinguish between these specific domains can result in a ruptured therapeutic alliance or a rejected dissertation. Mastering both environments ensures the practitioner can improve individual patient outcomes while contributing to systemic research. Navigating faith in modern psychology requires knowing exactly when to build a wall and exactly when to expand the map.